Computer. Hello, everyone, and welcome to COVID-19 Questions and Answers on KASU. I'm News Director Johnathan Reaves, and for the next hour, I'll be joined by my guest, Dr. Shane Speights. He's the Dean of the NYIT College of Osteopathic Medicine at Arkansas State University. We're going to be talking about COVID-19 and some of the key concerns related to the pandemic. Also, later in the program, I'll be asking some specific questions that listeners submitted over Facebook. So right now, let me welcome Dr. Shane Speights joining us over Zoom today. Dr. Speights, thank you so much for your time and welcome to KASU.
Thank you, Jonathan. Happy to be here and happy to be practicing social distancing via Zoom with you.
Absolutely. Let's talk about, for the past several weeks, the entire nation has been talking about COVID-19 and the impact that it's had on different areas in life. Many areas of the economy have come to a halt. And with other things in the past we've had to deal with, such as Ebola, MERS, SARS, H1N1, those other things like that, life didn't shut down like it has here with COVID-19. Can you explain why that is?
That's interesting. And so when we look back at those other viruses, first of all, certainly MERS and SARS, and even oddly enough, Ebola, they fall under some of the same viral families as the COVID-19. And I'll speak about that in just a second. But for your listeners, MERS back in 2012, I think it spread through into Saudi Arabia, never really affected the United States. And as we typically are, sometimes we're not as in tune with things that are going on in other parts of the world and other countries, and that might be why it didn't really hit people's radar. I want to jump down to H1N1. That was one that we actually had some planning on, and I think there was probably more preparedness than people really knew about. That was an influenza virus that was being spread rapidly throughout the world. And became a pandemic, actually came up through Mexico, first over into California, and was spreading rapidly. And it was hard to keep up with that virus. We were concerned at that time that the case fatality rate was going to be much higher, but as it entered the U.S., we found that it was not. It was very similar to what our seasonal flu, somewhat higher than our seasonal flu. But I want everyone to recognize there was behind the scenes planning going on, even with H1N1. We didn't have the restrictions in place. We didn't have the shutdown in place because we recognized once it started taking off that the case fatality rate or the mortality rate was not as high. Now move over to SARS. SARS showed up in about 2003. And the total number of cases worldwide were about 8,000 with 774 deaths. And it eventually just burned out. Why SARS is important is because what you're seeing now, COVID-19, we call it the coronavirus, and there's a lot of different things to be called by, but it really is a SARS virus. It's a SARS-CoV-2 virus. It shares about 70% of the genetic material as the SARS virus we saw back in 2003. In terms of where it originates from a lot of the same areas. And we think that this is just a mutated version of that. That virus, SARS, back in 2003, burned out basically. We were able to track it effectively, we were able to trace it, we were able to isolate people, and therefore we prevented it from becoming a global pandemic. Unfortunately, that's not been the case with this current COVID-19, or also called SARS-CoV-2, because it's so closely related. We've not been able to do that. The virus has gotten ahead of us in terms of testing, in terms of containment, in terms of isolation. The transmissibility and the infectious nature of it seems to be higher. It seems to be spread more rapidly from person to person. The new facts circulating now that the virus can spread asymptomatically, so somebody can have the virus for several hours or even a couple of days and not know it and spread it onto someone else. That's a problem. That is an issue that we also see with influenza, which is the reason why influenza can be spread so rapidly. Fortunately, with influenza, we have medications and vaccines. And in COVID-19, we don't have either right now.
So are these some of the challenges when you look at dealing with COVID-19, or there's some other challenges not mentioned yet?
Yeah, so in terms of COVID-19, that's one of the biggest challenges is the fact that it's so easily transmissible from person to person, which is why you hear the CDC talking about wearing face masks in public. It's why we've made such a big distance on the social distancing. It's why we talk about hand washing and hand sanitizers and disinfecting areas where large groups of people have been. It's why you see state and federal mandates in terms of people in close proximity. The virus can and has gotten ahead of us in terms of being able to accurately track it and trace it in the community.
Now, I'm actually going to move up to go to a Facebook question. Jonathan, that's a good name. Jonathan is a good that's a good name.
That's got to
But
be a great.
Jonathan on Facebook asked, some couples have reported both testing positive with COVID-19. One spouse barely had symptoms and tested positive, while the other spouse stated it was the sickest as she'd ever been. Why is that? Why does it affect some people more than others?
That is something that we still have yet to unlock. We know it has to do with the individual person's immune system. And so what we mean by that is it's how your body responds to a foreign virus, bacteria, or what have you. Some people, their body responds appropriately. Some people, there's a mild response. Some people, there's an over response. And it appears that over response can be the ones that really are creating the more severe cases and even the fatalities. There is an immune response called cytokine storm that's associated with this. And we do have individuals that seem to be, when that's triggered, those are the ones that have the more severe reactions. It, at this point, appears that and everybody's different, but about 5 to 7 days into the illness, you go one way or the other. You either start to recover fairly quickly with milder symptoms, or you turn the curve and start doing worse. One of the problems that we're also seeing is that it can turn quickly. And what I mean by that is an individual or a patient, certainly a hospitalized patient can be doing okay. They're needing some supplemental oxygen. And then within a matter of minutes or hours, they deteriorate to the point of needing to be on a ventilator or even death. We're not sure why that occurs in some individuals. We think it's related to the cytokine storm. We've actually had reports, we know of hospitals in the New York area that are requesting to have volunteers and medical students just sit and watch these individuals that are positive for COVID-19 because it's so hard for the nurses to get back to them. And they've had reports of nurses coming back on rounds and finding the patient has decompensated to the point of either near death or death. And so we're not quite sure exactly what an individual's genetic makeup is that they go down one path or the other. Early on, the information coming out of China was that this was truly a significant disease for those over the age of 80, 75 to 80 or older. Those were the ones that had the most trouble with it. Here in the United States and really over in Europe, we're seeing all ages are affected. It's still true that the older you are, the more likely you are to have a significant illness, but we're having individuals in their 20s, 30s, and 40s that are ended up on the ventilator and even dying from it. And so we have yet to really unlock the reason why. We will at some point, but at this point, that answer still eludes us.
And it's just like I saw something earlier where there was like a college baseball player who unfortunately passed away with coronavirus, but then you have people who are 70, 80 and even older who recover. And I think that's probably one of the challenges about that, why that happens.
That's exactly right, Jonathan, and we don't have the answer yet. Now, we know it's related to how, again, the individual's immune system responds to it, but we don't know if there's also a genetic makeup that also predisposes them to that or not. So hopefully we'll get those answers soon.
Why is underlying health conditions, why are those health conditions like diabetes and others, why do people with those seem to have more problems with COVID-19?
So just in general, when we talk about the human body, we talk about general health. You want your body in the best shape it can be in, just generally. When we talk about coming in contact with diseases and viruses, I mean, even whether it be the seasonal flu or the common cold, you want your body to be in good shape. Everybody knows somebody that if they get that cough or get that tickle in their throat, they're going to be they're going to be sick for a week with it, or I'm going to have this for the next 10 days or more. When we talk about a virus that is new to the human body, that has never been seen before by humans, and there's no memory cells within your system that can mount a response, you want your body to be in the best shape it can be to be able to fight off and be able to mount a response to this new virus. Any type of underlying disease or disorder that may hamper your body's ability to function normally puts you at a higher risk of not being able to do that. Now, we have seen a correlation in terms of the individuals that seem to have a harder time with it. Those individuals with a diagnosis of high blood pressure or hypertension seem to be at the top of the list. Individuals with underlying heart disease seem to be at the top of the list. Obviously, people with lung diseases, because this is a respiratory virus, they have a harder time. But even diabetes can suppress your immune system in terms of its function. So really any type of chronic disease can put you at a disadvantage to be able to fight off any virus, but certainly this one, which is brand new to the human body, and you would need everything that you can to be able to fight it.
Dr. Shane Speights is joining us here on KASU. He is the Dean of the NYIT College of Osteopathic Medicine at Arkansas State University. Here's another question here. How long do you think we'll continue to see cases of COVID-19?
I'll tell you what I'm reading in the literature and what I'm hearing from other from experts and from researchers. And here's the current thought right now. We anticipate we will continue to see cases certainly throughout the summer into the fall. There are concerns about the fall, and we can talk about that in a little bit. We will continue to see cases until there's a vaccine. And then even after that, we will likely continue to see cases, though hopefully in a milder form. We suspect that in the next 2 to 3 years, the virus will convert into somewhat of a seasonal virus, much like influenza. And in that case, you would probably see an annual vaccine, much like we do with the flu, for it. The virus, the COVID-19 virus, it's under the coronavirus family, which has a lot of different viruses under it. As a matter of fact, the common cold virus, 15% or more of the time, 15 to 30% of the time, is a coronavirus. And we don't have a vaccine for the common cold. The reason why you don't have that is because this family is notorious for being able to make mutations and genetic changes. And it changes itself about every 15 replications, or every 15 times it reproduces, it kind of changes its genetic code a little bit. And so that obviously means that you couldn't just have a one-time vaccine that would likely cover you for the next 10 or 15 years. The other piece that people need to recognize when we say, and I've had this question a lot, well, if I get it and I get infected, then I'll have antibodies in my body and I'll have immunity. How long does the immunity last? The most recent thing that I have read says that the immunity will last anywhere between 3 months to 18 months. And I realize that's a broad range. And again, I'll go back to one of the earlier comments. That is specifically based on your body's immune system. So it's how much of a dose of the virus you received and how your body responded to that dose of virus in terms of how many memory cells it has in place. And so that's why there's a wide range between the immunity that you would have after you get this virus.
So you were talking about, when you started that off, you were saying that, and it leads to this question. Do you think that COVID-19 cases will decrease in the hot summer months that are coming, or will weather have an immediate impact on this? What are your thoughts on that?
So we know that the coronavirus, or this COVID-19 virus, doesn't like the hot. It doesn't like sunlight, and it doesn't like hotter temperatures. In theory, we should see a decline in the number of cases in the summer, which means that, well, on the flip side, are you going to see an increase in the fall? And the answer would be yes, we would expect to see that. The fly in the ointment, so to speak, in all of this is what we're doing as a nation and as a community to respond to the virus. So right now, 95% of the United States is in a lockdown or shutdown of some type. That's 305 million people in the United States are on some sort of stay-at-home order. Well, that obviously dramatically reduces the spread of the virus if people are truly doing that. If we start to loosen those and people start going back to work, and I know that's a question that we'll be talking about later as well, and people start socializing again and groups start coming back together, you'll see a resurgence of the virus. That's something that actually we expect to have happen. Well, what does that look like, and when does that happen? So is it possible that the numbers we're seeing now are lower than what we will see in July? Well, it's possible, because it depends on how we as a community, how we as a state, and how we as a nation respond to this virus in terms of our social distancing. It's very likely that we would see more cases in July if we've relaxed a lot of our social distancing policies and regulations.
We're going to take a break. You're listening to COVID-19 Questions and Answers. I'm Johnathan Reaves. We've been talking with our guest, Dr. Shane Speights. Dr. Speights, thanks for joining us. We will take this quick break. You're listening to KASU, streaming live at kasu.org. Back after this. This is COVID-19 Questions and Answers. I'm KASU News Director Johnathan Reaves, and my guest this hour is Dr. Shane Speights, who's the Dean of NYIT's College of Osteopathic Medicine at Arkansas State University. Dr. Speights, once again, thank you for your time. We really appreciate you being here with us today.
Thank you, Jonathan. Glad to be here.
One of the things that I wanted to ask you about, we kind of talked about this before we took the break, is about what the future may look like. Some people are really anxious to get back to work and with this. So there's been talk about starting to get back to work, opening the economy up, and that. How do we do that and minimize the spread of COVID-19?
So, gosh, that's the $1 million question right there, Jonathan. And I think everybody's grappling with that, from the federal government all the way down to the state and even local governments, in terms of what does that plan look like. I'll say some things with some certainty, but realize there's a lot of uncertainty out there. I will say this with almost absolute certainty. We won't just flip a light switch and everybody just goes back to work and goes back to school and you start having concerts and large gatherings. That won't happen. That would be negligent, I think, on all parts to just do that. So what you're left with is some sort of staged or staggered approach. And it'll be under probably some sort of triage level. So who do we need to get back into the workforce now that we can safely do so, and we can still enact and practice social distancing within that different industry? And so you'll look at certain segments or sectors and start implementing that there. I think that you'll continue to see the recommendation of wearing face masks in public. I think that's going to be here for quite some time. I think there still will be recommendations of, if you can telecommute, then you should do so. If you can continue to do your job from home or from a location where you're not surrounded by anyone, then I think that that's going to continue to be encouraged. I do feel that there will be more emphasis put on actual testing and tracing or tracking of individuals. We would have to have that in place to be able to start to reopen some of these sectors and these workforce populations. The reason why is because cases will go up. When you reopen things, the virus, all it wants to do is jump to another host. And so it will spread, and we expect that to happen. We will see spread of the virus when we start opening things up. But we have to. We can't live like this. This is not something that our economy can tolerate. It's not something that individuals and families and workplaces can tolerate forever. And so we have to do this. We just have to be smart about how we do it. We also have to realize that as we open things back up, when we see these pockets of infections, we'll have to shut things back down. And so you're going to see things open up, and then you'll see things shut back down. And that will occur. These ups and downs will occur probably for the next 12 months or so. And people will say, well, why is that? At some point, there's got to be a stopgap or a piece where we don't have to do that, a part where we don't have to do that. And that's exactly right. And where we stop doing that is two things. Either there's enough people in the population that's become infected with it that herd immunity is created, or we have a vaccine. It's been estimated early on that for us to have herd immunity in the United States, half of the population, or about 165 million people, have to be infected. Or we have to have a vaccine that protects everybody from it. At this point, we've got 3 vaccines that are entering human trials that are very promising, and we're hopeful to have those by early to mid 2021. So that's kind of where we stand now in terms of how long do we have to deal with this back and forth as we start to slowly reopen the economy and reopen businesses and the educational sectors and areas like that. There's not really, in my opinion, a perfect answer. I think we'll do the best that we can based on the evidence as we learn more about the virus.
You mentioned herd immunity. Patty asked this on Facebook about creating herd immunity that could help defeat the virus. And she was also asking, if you get it once, can you get it again? Can you talk about those thoughts on herd immunity, and can you get it more than once?
You know, I want to take just a second, Jonathan. I want to tell you, I do several interviews. I've done quite a few interviews. Your listeners ask the best questions. I want you to know that when I do interviews with you and KASU, you guys really put out the best questions, very thoughtful questions that when I sit around with other physicians and researchers and experts, we're asking the same thing. So kudos to you and your listeners, because you guys asked some really good ones. So back to Patty's comment in terms of the social distancing and the herd immunity. Herd immunity will be created when individuals within the population get infected by the virus and create antibodies. And so that means that once I've gotten infected, so let's say, for example, I've got 6. I've got 6 people in my immediate family, 6 individuals in my family. And so let's say 5 of us got infected, but the 6th one didn't. The 6th one stayed at home. The 5 of us got infected. We all got over the virus, and we have antibodies. So the fact that our herd is creating immunity for that 6th person, and that's the way herd immunity works. And herd immunity is different for each infection. So herd immunity it's not a standard. It's not that, okay, you have to have X% of the population be infected. Like for some viruses or some infections, like measles, for example, you have to have a high percentage of individuals to be able to provide herd immunity, which is why we make such a big deal about measles outbreaks and things like that. From what we can tell on this virus, we need about 50% or more of the population to create herd immunity. So I hope that helps. And I'm sorry, she had one more piece there in terms of, can you get it again?
Yes, if you get it once, can you get it again?
So, and again, that's a very good question. That's something that we're just now coming up with. In South Korea, there was a report that just came out that they had 116 patients that had the virus, documented cases of the virus, documented that they recovered, and then turned around and came back positive again. Now, this positive, from what we can tell, it was not an infectious positive. They were just tested, I think, for surveillance reasons. They were shedding the virus, but it's not clear on whether it was enough viral shed to create disease. So basically, these 116 people, they were shedding an amount of the virus still, even after they've recovered from it, but we don't believe that it's enough to actually make somebody else sick. We're not sure why that is. And that's one of the big questions being circulated, obviously, amongst the researchers is, what does this mean? Are there public health implications to that? And to be honest with you, the answer is we don't know.
Dr. Shane Speights joining us here on KASU. Let's go back to the economy. Some people question if we're overreacting to this and doing unnecessary damage to the economy. As it's been put out there, could it be that the treatment is actually worse than the disease? Your thoughts on this?
You know, I've heard that. And first of all, let me be very clear. I'm cognizant and I readily recognize the economic impact of this. We have to find a way to move our economy forward. I think we should be using this time to create innovative and new ways to move our economy forward that may or may not involve the way that we always did things previously. The short answer is the virus doesn't care. The virus doesn't care what the economy is. The virus is going to move from person to person and infect people, and people will get sick and recover, and people will get sick and die, and that's just the way it's going to work. the virus doesn't have any kind of inkling of what the economy is. But here's certainly one of the positive things and the positive takeaways. When we look back at history, specifically if we look at the Spanish influenza pandemic, which a lot of people have correlated this with, back in 1918, the economies bounced back, and they bounced back rather quickly. Just to pull a phrase, if you remember the term the Roaring Twenties, that was after, now granted there were other things that were going on, but that was right after the Spanish influenza of 1918 that was so devastating to our country and to the world. And so I feel very comfortable in that our economy, once we get it going, we will bounce back, and we'll bounce back stronger. That's the history of our country, is that we move forward. We look at adversity and we move forward with perseverance and with determination, and we'll do that again. So I have no doubts of that. But I do recognize that the place that we're in now, we've got to somehow move forward. I would go back to say, I know us at NYT, in terms of what we have done, is we have leveraged the use of technology, just as we are now with this Zoom interview. We are using that with our students. We're using that in faculty meetings. We're using that for any of our administrative meetings. So for us to try to continue some sort of day-to-day, we have shifted every single meeting we normally had to a Zoom platform. So that we can continue that. I realize that everybody can't do that, and there are obviously sectors of the workforce that have to be face to face or have to be out in the general public. But we should look for new ways to be able to use what we have to get the economy going quicker.
Here's a late submitted question from Andy. Andy asked this: how do we know that social distancing is really working in combating this COVID-19?
Oh, well, that's actually a fairly easy one, because we look at other countries who didn't enact it. We look at other cities and states who didn't enact it earlier, and I think Arkansas is a really good example of that. One of the things that I've said very early on, when people have asked, well, how will we know what to do next, or what's coming next? And I said, well, just look to the East Coast or the West Coast, or look at other countries, because it's moving in this direction. But we can see how other communities, states, and countries respond to it, and we can take notes from them. And that's what happened. And so here in the state of Arkansas, we enacted, our governor, through the direction and support of our Secretary of Health, Dr. Nate Smith, who I can't say enough good things about. He's doing a phenomenal job. They enacted things very early on that would have just been laughed at in areas of the East Coast, had they done it at the same time. And so we learned from that, and we enacted those earlier. Because of that, we are seeing a more flattening of our curve sooner than expected. We're not hopefully going to see the surge that we were predicting earlier. Now, that's not to say that we can't see an uptick as we start to loosen some of these social distancing regulations. But right now we have it. And that's because for the large portion of our population, they're staying at home, or they're limiting interaction with people, or they're wearing face masks, or they're doing a great job of hand washing. So I think that really you just look across the country at the different models that are doing social distancing and doing it right. And I think it was California, when their governor implemented their requirements, they start seeing a drop off almost immediately. It's the way the virus is spread. The virus is spread from one person to the next. Well, if you don't have a person standing next to you, the virus doesn't spread. And that's just the simple genetics of it. That's the simple immunologic tracing of how it's moved.
Here's another concern. If you don't mind defining what this term flattening the curve is, because we've heard about this. Some people say, well, how is it that we're flattening the curve, but we're seeing the number of cases increase? There's some confusion there by way of that term. Can you please explain?
Absolutely. It's the rate of increase that we're referring to. And I've heard, and I've had this comment before. I hate to admit it, I think my own daughter, college age, had said, well, why don't I just get it over with, and just go ahead and it just, if we feel like most people are going to get sick at some point with it, get the vaccine. I'm young. Why don't I just get it over with? When we talk about flattening the curve, what we mean is we want the fewest number of individuals to get sick at the exact same time. We assume that most people will come in contact with this virus at some point, or they'll get the vaccine. That's kind of the things that we're thinking is, okay, you're either going to kind of get this, or you're going to get the vaccine, you'll be protected by it, or we'll have a medication available that can limit or blunt the symptoms or the severity of it. So a couple things happen if we flatten the curve. If we flatten the curve, we decrease the number of people that are infected at one given point. If you don't do that, if everybody just got infected at the same time, you rapidly overwhelm your healthcare system. And that's where you run out of ventilators and run out of doctors and nurses and ICU beds and hospital resources and clinic resources and everything with our healthcare system that keeps us well. It would, in fact, obviously, if everybody got sick at the same time and got over it, well, yeah, that sounds neat, but you would have more deaths then. You would not be able to deploy resources as needed to the individuals who were the sickest. Also, when you flatten the curve, you give us time. And when I say us, you give the medical community and the researchers and the vaccine makers and the pharmaceutical companies time to create a good vaccine or to create a good medication or combination of medications that can be used to fight it. And so by slowing the spread, it gives us time to catch up to the virus. Right now, the virus is ahead of us. As we slow the spread, we catch up to the virus. Now we can track it better. We can trace it better. We can isolate people better. We can give, like I said, give ourselves time in terms of medications and vaccines, and we don't overwhelm our healthcare institutions.
There's been a talk about an eventual peak in cases and then gradual falling of that. How will we know when we've reached that peak?
That's something we just continue to watch in terms of when that peak occurs. It's a trend line. It's something that we basically, it's a best guess in terms of, and it's been a moving target really ever since it started. So I'll just say for us here in Arkansas and in specifically Northeast Arkansas, at this point, we're looking for a May to mid-May peak is kind of what we're looking at. There are some models that say June, and there's even one or two that push it out to July. One of the things that and it sounds counterintuitive, as we do a better job of social distancing, as we do a better job of flattening the curve, it pushes out our peak even further because we flatten it. And again, that the idea behind that, and about the same number of people are going to get infected. It's just the timing that they get infected. We want the fewest number of people infected at the same time as we can, and that's where the flattening comes in. So I hope that helps. I hope that's not too confusing.
No, and one of the things to kind of follow up and piggyback off of that, is there a way that we'll be able to know, and you were saying it might be, May up to July. How will we know when we reach that peak? Is it all numbers
Okay.
based or those kinds of things? How will we know when we reach that area?
It largely is. You'll see hospitalizations. You'll look at number of cases, and hospitalizations will flatten out, and then they'll start to decline. Just so that people know, don't be surprised if the death numbers continue to rise even after hospitalizations and number of positive cases start to go down. It's because there's a lag. And so once a person tests positive, there's a course of the disease that can go anywhere from 3 days to 30 days. And so if it's an individual that's particularly having trouble with it, they may not succumb to the disease for several weeks or more. So the deaths will lag behind hospitalizations and actual positive test results.
You're listening to COVID-19 Questions and Answers. When we come back, when we return, it's your Facebook questions that you've submitted to Ask Dr. Shane Speights, who's our guest for the hour. You're listening to COVID-19 Questions and Answers on KASU. All right, here we go, Dr. Speights, for the last segment here. This is COVID-19 Questions and Answers. I'm Johnathan Reaves, News Director with KASU. My guest this hour, Dr. Shane Speights, Dean of NYIT's College of Osteopathic Medicine at Arkansas State University. As promised, now we're going to get to some of the questions that were submitted on Facebook, so we're going to go ahead and dive right into them. Mark asks this: Dr. Speights, what are some of the rumors that you're hearing that are not true about COVID-19?
There's That's a good question. It's kind of a hodgepodge, and let me go into that. First of all, COVID-19 is not like the flu. I think that people get a false sense of security when they say this is just like the flu. But we don't have medications for this virus. We don't have a vaccine for this virus, and this is a virus that the human body has never seen before. Most everyone, if you've either gotten a flu shot or gotten the flu, your body has created memory cells to remember that virus when it sees it again. Even if it's not the exact same virus, it remembers parts of it. So this is not the flu. This is not influenza, and I hope people can recognize that. There's a lot of media hype going around back and forth, and so I would be careful in terms of the things that you hear on the news. It's, certainly the major national outlets, and assume that it applies to us here in Arkansas. And so I really heavily depend upon the Arkansas Department of Health and their leadership and their statistics. Now, it's not that we ignore what's happening across the country, across the world. It's just that we need to recognize that this virus, the way that we approach it, the way that we are going to get out of it in terms of reopening our state and our region, it's going to be largely a statewide or a community-wide response in how we do that. We have to respond to how the virus is circulating in our community. Regardless of what happens in Miami or in Denver or in St. Louis, we need to respond to it here because that's what's most important for us. There were some other things, somebody had said something about they thought that they got this back in September. No, you didn't likely get this back in September. One of the things that is good about this is that there's a lot of researchers taking this virus and they're looking at the genetic code very closely. And we actually put that into a public database so that everybody can look at. And so, which I think is fascinating. And we can trace this back, and we know based on the genetic makeup of this virus that it didn't make the jump from animal to human until sometime at the end of November of 2019. And so that's when this virus truly started to spread. The other piece is that you've heard this, that it's germ warfare, or that this was created in a lab somewhere. Again, based on the genetics of the virus, we can tell that this is not a lab-made, man-made virus. It's got too much animal DNA and too many things in it that point to the fact that this was something that made a jump out in the environment, out in nature, and was not created in the lab. So those are just a couple of the things that I've been hearing that we try to speak to.
Right. John asked this: NYIT is a hands-on teaching environment. What are you all doing to be safe and effective to educate and graduate future doctors in an environment where healthcare workers are contracting COVID-19?
Yeah, and again, another good question. Nothing replaces the hands-on education, certainly that they get at an osteopathic medical school through the osteopathic manipulation labs, what they do in their gross anatomy labs, even the standardized patient experiences where they're in front of a mock patient. However, we have been very fortunate in that we can utilize technology to help fill those gaps. And I'll give you an example of that. One of the things that has taken off, and you'll see this in other areas, other industries, but certainly in healthcare, there's this boom now of telemedicine visits. And so you see a lot of that. That's something we were actually teaching our students early on. So that was part of our curriculum. So we've just kind of ramped that up a little more. And so what we can do now is we can have these standardized patients over like a Zoom forum where student does the interview over a televideo. And so the student can still be tested in terms of how they ask questions, their facial expressions, how at ease the patient feels. Are they able to elicit the correct history, the past surgical history, the past medical history, past family history? All of those pieces they can still be assessed on. And so it's not perfect, but certainly it does allow us to move forward in the education of tomorrow's physicians. So we're obviously eager, just like everyone else, to get back to work and get back into the buildings and back into the labs. But at this point, we're going to have to do the best that we can. And the same thing occurs even in our clinical years. nationwide, medical students from all schools have pretty much been taken off of a lot of their rotations. So, mostly due to the hospital's concerns about not enough PPE and students' well-being. So how do you mitigate that? Well, we have online rotations that they can take in terms of like addiction medicine or telemedicine. There's even some radiology modules. We have different modules that they can take online that continue their education in the absence of that face-to-face patient interaction right now.
Gail asked this question: what are your thoughts on the way Arkansas is screening people for fever and symptoms before testing, given that asymptomatic people can transmit and infect others?
I agree with that. I think what she's referring to is that you'll see people in front of I don't know, maybe even a grocery store, or before they walk into a building somewhere, and they get that forehead screening for a temperature. I think that's a good idea, and I agree with that. As more and more evidence about the virus comes out, we are seeing that there is a percentage of individuals who can pass this virus and not know it. Latest numbers from CDC is that about 25% of individuals that are sick with COVID-19 can pass it off before they actually have their own symptoms. And so that kind of screening process, I think, is great. Because again, it goes back to how quickly can we identify these individuals and isolate them to prevent the spread of the virus throughout the community. So you'll probably see more of that. You're going to hear about things about like apps on your phone that can track infected individuals and that can track COVID-19 cases in your community. A lot of this is going to come out as we start to reopen the economy so that we can continue adequate testing and tracing.
Right. And speaking about that, we talked a lot about the economy in the last segment. And I forgot to ask you this, but I'll go ahead and ask you this real fast before we continue on. What do you think future events will look like, such as concerts, sporting events, going out to eat, those kinds of things, when we start trying to open things back up? How do you think that is by way of what the future will look like?
So again, I fully expect that this will be a staggered approach. And so what it'll be is you'll have certain sectors that'll open up first, and then there's going to be a wait and see period and see if the virus, rears up. And what we're looking for when we say it rears up, we're looking at does it hit a threshold where there's a critical shortage of healthcare needs, of healthcare resources, basically. So, because we don't want to get to the point where we don't have enough ventilators, we don't have enough, resources, enough PPE and that sort of thing. So we fully expect that will be the big piece of the monitoring. And so because of that, you'll open up a few things here and there. They'll talk about maybe even staggered openings of K-12. It could be, I've seen different things thrown out there in terms of, well, maybe we start back to school and it's a month on, a month off. Maybe you do a month on, a month off, month on, month off, and maybe we do that. Or maybe we just go back with elementary school students or intermediate students first, and then we hold back junior high and high school students, and then we start them a month later or 6 weeks later. You're going to see these different 6-week, 8-week approaches. In terms of concerts and large gatherings where you've got the potential for thousands of people, that will probably be the last segment that really opens up, is what I would think. Just because with a mass number of people, like at a concert, there's so much potential for viral spread in a small confined area. And you typically, like I said, a concert where you're bringing in people from all over the region. And it doesn't take much at all, as history has shown us just recently in New Orleans. It doesn't take much at all for those individuals to come together, and then you have large numbers of infections that can quickly overcome the healthcare environment. And so it'll take a while, and I mean, people out there are going to have to be patient, but we'll get back there. There's no doubt in my mind that we'll reopen, and we'll be stronger than we were before. I think that's going to be one of the interesting things to see, is how things do change when we go back. We'll find, I think, that things that we never thought we would do, we're doing, and things that we never thought were possible are now possible. So it'll be a different world, I think, when we go back.
Yeah. Let's go back to Gail. She wants to know your thoughts on recovered patients now seeming to test positive after recovery and testing negative. What are your thoughts on that?
So that is, at first we weren't quite sure about that. There were about 4 patients, I think, in China when the cases of that first came out, and so we weren't quite sure, kind of scratching our head. And then most recently, there's been a study out of South Korea with 116 patients that had documented cases of COVID-19. It was documented that they went through the recovery period, and then again documented that they were positive. Now, the caveat is these individuals, from what we can tell, were not sick. So even though they recovered and tested positive again, that second positive test, they weren't ill. They didn't have, fever or, significant issues with the disease. It wasn't an illness that they were documenting. It was just, I believe, for tracking purposes. The other piece is we don't think that they can spread the virus at that stage. So what does all that mean? What does all that mean if you're shedding some of the virus? I'm not sick, but I can't get anybody else sick. What does it mean? Well, we don't know what it means, and because it's a fairly new thing that we're picking up on. And do different people shed the virus after that recovery phase at different amounts? There's, we have people that you'll hear about in the literature called super spreaders. That are spreading the virus and that can spread the virus to multiple large groups for whatever reason. They're able to spread to large numbers. So there's a lot of questions we still don't have the answers to, and I'm not sure how to really answer that other than what I've just told you, is that it's not clear at this point what that means. Though we do feel like that it's not a second infection where they're sick again.
I did an interview recently with a healthcare professional who's on the front lines. He was talking about what his main concern is that people are not going to the doctor because they're afraid of getting, COVID-19. And what he's afraid of is that when you have like a lot of people in the healthcare field that are trying to treat patients for COVID-19, then the people who should have gone in to see their doctor for, either heart issues, diabetes, or all that they may be coming in as well. What are your thoughts on that concern by way of that possibility of flooding the system?
I think that's a great point. One of the things that we always worry about when we talk about a pandemic or you talk about a disaster of any type is that during a disaster or pandemic, regular things don't stop. And what we mean by that is heart attacks don't stop, strokes don't stop, babies are still born, people still have gallbladder attacks and those things. And so, that those things are still happening. One thing that you are seeing in many hospitals, though, is the reduction of elective surgeries or elective procedures. So basically, if you were needing to have a knee replacement or, and it was something that was just bothering you for the last couple of years, for the most part, those surgeries are being put off to reduce the patient's risk of getting infected in the healthcare environment. I think that's going to be a balancing act as well in terms of how do you start reopening those areas up and keep the patients safe. At the end of the day, we've got to make sure that people stay safe and well as much as we can. It's a highly transmissible, very virulent virus, and it's going to spread when it has the opportunity. And so we just have to do the best that we can to reduce the risk of spread in all areas of healthcare.
Anne asked this question: how concerned are you about the obesity rate in the state, since people are stuck inside and some are still trying to be active? A lot of people are not because they're afraid to leave their home. Your thoughts on the obesity rate?
One of the issues that we face here in Arkansas, and it was certainly one of the driving factors behind bringing NYT as a medical school to the Arkansas State University campus, and a pinnacle reason why we at NYT started the Delta Population Health Institute. Arkansas continues to rank toward the bottom in terms of healthcare outcomes compared to the rest of the nation. That's one of the things that concerns me in terms of the models and the number of infected people and what our outcomes look like, because those models don't necessarily take into effect that we have a high obesity rate, that we have a high premature death rate, that we have a higher rate of diabetes and cancers, and our physical inactivity rate is higher. Those don't really go into those projections and those models. So to the listener's question, that's exactly right. It is a concern, and I do worry that we will fare worse here in Arkansas and in the South, Louisiana and Mississippi as well, because of the poor health status of our general population. That's also the reason why I've encouraged from the beginning for people, look, just get out and walk around your neighborhood. I'm not expecting you to go run a 5K or run a marathon. Just walk. Just get out and walk around the neighborhood. We're finally starting to see some nice weather here in Northeast Arkansas and in our region. Take advantage of that and increase your physical activity. How much should you do? At least 5 times a week or more. And don't start off, like I said, walking 15 or 16 times around your neighborhood. Start off walking off, a little bit, and then just try to increase it every few days or so as to what you can tolerate. Obviously, it's a discussion you want to have with your physician as well. But for the vast majority of individuals, this is something that you could easily do to increase your health status and help you in terms of being able to fight off this virus if you were to become infected.
Here's the last question for you. What's the best advice you can give people to protect themselves as we go forward? How do people protect themselves?
I still believe firmly in the social distancing. I also believe in the wearing of the mask in public. The wearing of the mask in public, you'll hear people say, well, if you're sick, then you don't get anybody else sick. It does also protect you. It's not as good as the N95s or surgical masks, but those should be reserved for our healthcare providers because those are needed there. But the wearing the mask in public does protect you as well as somebody else. Washing hands, I know that I've said that till I'm blue in the face. All of those things work, and we are proof that it's working based on our ability to flatten the curve in Arkansas. And there's other states that are able to do this as well, that are showing that these measures reduce your risk of infection and also reduce the risk of people around you getting infected. And one of the things that I would probably end with is there are a lot of opinions out there. There's a lot of blogs, a lot of posts here and there, and I would encourage your listeners to trust the science and to trust the individuals that are putting out the current information, the current evidence that you can point to. In terms of a CDC recommendation, an Arkansas Department of Health recommendation, a specific journal article that points back to it. And so in this day and age, there's a lot of misinformation. And so I just try to encourage them to trust the science, trust the physicians and the researchers that are putting out good information.
Dr. Shane Speights is the Dean of NYIT's College of Osteopathic Medicine at Arkansas State University. He's been my guest this hour for COVID-19 Questions and Answers on KASU. More information is available on our website at kasu.org, where you can look for the coronavirus page. We're giving you the very latest information and also updating Governor Asa Hutchinson's press conferences on a regular basis. Thank you so much for your time today. We really appreciate you joining us, and been a great program and a great time to talk with you today. So thank you so much for your time.
Thank you, Jonathan. Always enjoy speaking with you and your listeners about any of these hot topics that are going around.
COVID-19 Questions and Answers on KASU. Thank you so much for listening. Have a great day. I'm Johnathan Reaves for KASU.